So I'm Joe Rosales. I'm one of the medical oncologists here at Virginia Mason, just up the street here. I'm actually on call this weekend, so hopefully I turned off my phone. I've been here at Virginia Mason now for about 8 years, mostly doing actually lung cancer, thoracic oncology, lung and esophageal. Prior to that, I was in private practice in Spokane for almost 5 years. And so in the process of having been an oncologist for the last almost 15 years, it is common, especially here in Washington, but just in general, to have patients ask about medical marijuana and whether it's appropriate, what it is really used for, and what's the best way to try to use it. And so in that context, I've become really interested in what exactly the data looks like for marijuana. There's a lot of hearsay, a lot of websites that patients go to, and it's really hard sometimes to separate the real data and the common knowledge. And so I guess it makes sense to get into that right now. Oh, it's not working yet. All right. Just, oh, okay. Just actually, as a quick poll, how many people here have recommended medical marijuana to their patients? One. How many people here have had patients ask them about medical marijuana? Yeah, and it's kind of hard just because you don't quite know what to say, and so hopefully this will be helpful for everybody. How many people here are taken? Never mind. You don't have to answer that. Oh, speaking of which, I have no disclosures, at least nothing I can say in public with regards to this. So this is a quickie learning objectives. Number one, just a brief history of medical marijuana. It's been around for a long time. The controversies over it are relatively recent, like in the last 100 years or so, but it's been around for several thousand years. We'll review some of that. We'll talk a little bit about the basic science, the mechanism of action of medical marijuana. Also, the meat of this is going to be the clinical data, specifically as it pertains to oncology. There's a broad range of topics within medicine that pertains to medical marijuana. We'll keep it within oncology for now. And also, we'll touch a little bit on the legal issues. I mean, here in Washington, we don't have as much of that, but throughout the country, there remains ongoing issues, especially at the federal level. So, probably the earliest mention or any proof of of marijuana use, cannabis use, goes back even about 8,000 years from now, 6,000 BCE. Cannabis seeds, not necessarily used as medication, but used as food in ancient China. They also use it as textiles, hemp. So it goes back several thousand years. The first use, or mention of it as use in medicine, probably about 4,000 years ago, almost 1800 BC. The Egyptians, the first time, used it to treat sore eyes, presumably glaucoma, but not necessarily sore eyes. And then about 1,000 years or so ago, in the Indian subcontinent, used marijuana for many things: insomnia, headaches, GI complaints, and pain. Interestingly, when you look at the history of marijuana, as a quick aside, in Western medicine, so Rome, Greece, they use marijuana more in clothing, textiles, and rope, hemp, whereas in India, they use it a lot more for medication, psychotropic uses, and I think a lot of it has to do with the strain of marijuana that grew where, and we'll talk about that in a little bit. But in Western medicine, or in Western use, classical, the very first mention of it goes back about 500 BC. Herodotus had it was a historical text, it wasn't a medical text. So the seeds of this hemp, upon burning stones, and immediately a more agreeable vapor is emitted than from the incense burnt in Greece. The company extremely transported with the scent how allowed. So people were worried that this is one of the propaganda from marijuana or against marijuana historically, is it makes people kind of go crazy. This was, as an aside, during a funeral for a warlord, so everybody was probably kind of drunk and sad anyway. Pliny the Elder, another historical figure. The virtues of hemp, it is said, are so great that an infusion of it in water will cause it to coagulate. Hence, it is that if taken in water, it will arrest looseness in beasts of burden. So in veterinary medicine, it helps with GI complaints. Dioscorides mentioned it as a round seed, which, if eaten, reduces sexual activity, but being juiced when it is green is good for pains in the ears, and so just small pains. And then Galen, who is oftentimes considered the founder of Western medicine, certainly Roman medicine, mentioned that hemp cakes, if eaten in moderation, produce a feeling of well-being, but taken in excess, they lead to intoxication, dehydration, and impotence. So it goes back, the medical use of marijuana goes back at least a couple of thousand years and potentially more. In Western medicine, so Europe and in America, it really became more widely used in the mid-1800s as a consequence of the work of this one man, Dr. William Brooke O'Shaughnessy. So if you ever look at the history of medical marijuana, this guy actually figures very prominently in it. From a lot of it is legend. He's a couple hundred years old now, but from the sounds of it, very smart guy. He came from poverty to become a doctor in Ireland, which apparently back then just did not happen. So the fact that he wasn't a privileged individual and went to medical school anyway, you could tell he was smart from the get-go. He studied at Edinburgh, and his claim to fame was he helped treat the cholera epidemic in England in the 1830s. People were dying of cholera. It was his idea to start IV fluids, saline IV fluids. And because of that, people who were dying from dehydration, not so much from the infectious disease, but from the dehydration from the diarrhea, were saved. And so, because he was so prominent, the rulers at the time said, well, you can do whatever you want. Where do you want to practice medicine? So he ended up moving to India in 1833. And while there, was actually very active because the British colonized India, and there's a large British presence there. And he actually was very prominent in the Indian medical community. He actually compiled the Bengal Dispensatory and Bengal Pharmacopoeia, and it is in that process that he learned a lot about cannabis, marijuana. And when he came back to Britain about 20 years later, it was him that introduced that as a medical tool in Europe. So what exactly did he find? So when you look at marijuana in general, so there's two general strains. There's cannabis sativa and cannabis indica, traditionally. There's also cannabis ruderalis, which generally doesn't really have any pertinence in this. You can tell that there's differences in terms of their leaf structure and what have you. But the important thing with sativa and indica has to do with the enzymes that they have in the plant itself. So we'll talk about this in a little bit. There are probably 70, 80 different cannabinoids that are considered to be present in medical marijuana, but there are two that are the most prominent. And when you talk to your patients or they ask you questions, they'll ask you about THC and CBD. And whether or not a plant has THC or CBD depends on which enzymes they have predominantly in that particular strain. If you have a plant that has THCA synthase, it makes THC. If it has CBDA synthase, it makes predominantly CBD. And as a general rule historically, cannabis indica makes THC, and cannabis sativa makes CBD. There's more than just that. Like I said, there's maybe 80 different kinds now, but predominantly there's the CBD strain or the CBD group of molecules, and then there's the THC group of molecules. And depending on which one, it's what generates a lot of the medical activity of marijuana. The THC ends up giving us the psychotropic, so the high really comes from the THC. It's also the part that's a very good analgesic. We'll talk about the pain medicine component of this. It's also the appetite stimulant, so people that, I've heard that when people smoke marijuana, they get hungry afterwards. That's the reason why. And also, it contributes a little bit to paranoia and anxiety. So a lot of the CNS activity is mediated by THC, the tetrahydrocannabinol. CBD, on the other hand, tends to be more of the anti-inflammatory, the calming effect. It has not as much of the psychoactive effect. It does have some pain effect also, but more peripherally. So that's cannabidiol. So depending on whether it's a predominantly indica plant or a predominantly sativa plant, you have different concentrations of either THC or CBD. In reality, though, let me go back. In reality, that's really been blurred because there's so many different strains now that have been interbred over the course of the last several hundred years. And that's one of the potential problems really when you're giving somebody advice regarding medical marijuana. There's no regulation for it. You can't just say, you can take prochlorperazine 10 milligrams every 6 hours, that'll help you for your nausea. There's no such similar recommendations for marijuana because there's dozens of different kinds of strains, and depending on which one you use, it has different concentrations of CBD and THC and combinations thereof. Also, depending on where you go, like what state you go to, even within the same city, what dispensary you go to, they have different products. So there's no standardization of products. So because of that, it's really hard to say to somebody, this is what you should take. A lot of times when I give advice, I say, well, try different kinds for this very reason, depending on what symptom you're trying to treat. The way that both of these work, both CBD and THC, is they attach themselves to the cannabis receptor. There's several different kinds. This is kind of your standard sort of 7-transmembrane protein gateway receptor that we learned a lot in biochemistry. There's more than just two, but the two that are most prominent are CB1 and CB2. Interestingly, their location a lot of times mediates their activity. CB1, for instance, is present in high concentrations in brain tissue, muscle, the GI tract, pancreas, liver, and adipose tissue. And a lot of times that's what that mediates things like the pain centers or the appetite stimulation or the antiemetic centers. CB2, interestingly, are present in immune cells, T cells, B cells, monocytes, tonsils, and spleen. And there is some data, not so much used in cancer, but there is some data that shows that there is a real anti-inflammatory effect in cannabis. Just one of the things, actually one of the really good studies that were used in cannabis are in patients that had ulcerative colitis. People who had progressed on multiple treatments, half were given cannabis, the other ones, half were not, and the people that got a significant dose of cannabis ended up decreasing or being able to take off their prednisone. And so there's definitely an anti-inflammatory component to it, still very early in its understanding. But because of that, that sort of gives us the potential effects of marijuana. Oh, there we go. So for instance, and some anti-inflammatory effect, bronchodilation, it can help with control of bronchial asthma. There's some definitely some good data against an antiemetic effect, so it prevents nausea and vomiting. There's an appetite stimulation, not as strong of a data, but appetite stimulation in cancer patients, but also in HIV patients. There's definitely good data on it in analgesia. Decreased spasticity in multiple sclerosis and sort of other organic brain injuries, and traditionally has been used for decreasing intraocular pressure in glaucoma also. But like I said before, how do you really use it? You can't just give somebody generic advice about marijuana. And there really is no such thing because there's no regulation. In fact, there's different formulations of medical cannabis. So there's the standard one, smoking. I tend not to recommend that for various reasons, but mostly because of the potential for infection. A lot of times when I'm talking to my patients about it, they're getting chemo and they're getting immune suppressed. And you don't necessarily want to give somebody a weed product that might have bacteria, that might have fungal elements in it if they're also going to be immunocompromised. So I hardly ever recommend this. I mean, they might do it, but I tend to have them go against it. Vaporization is different because it's still smoking, but it's more of an extract, so it's more purified. There's less potential for infectious issues. The good thing about these two, smoking and vaporizing, is that the effects of the CBD or the THC are pretty rapid, within the matter of a few minutes. Now, it's also gone because it gets filtered through your system quickly, but it's good for controlling things like pain. You take it, it's rapid onset. When you're done, it's kind of gone. So it's good for things like spasticity and pain. Has its benefits that way, but the downside is that it won't last for very long. On the other hand, things like oral ingestion or oral mucosal. So oral ingestion is a pill or a powder. Oral mucosal are usually things like ointments or oils that you put underneath the tongue or in the buccal mucosa, so that you can absorb it that way. The onset of action tends to be slower, in the order of maybe 15 to 30 minutes, but it lasts longer, perhaps several hours, because it kind of gets filtered through the GI tract. I've never had anybody go through it. I mean, there's rectal absorption, but I've not had anybody do that for the same reason. You don't want somebody who's potentially neutropenic on chemotherapy causing any problems with their GI gut. And there's different formulations of it. So there's a standard one, so cannabidiol and THC. These are the ones that you ingest naturally. There are a couple that are approved, both in the US and also in Europe. Like for instance, down here, so the Marinol, dronabinol, or nabilone sesamet, those are synthetic THCs. So pros and cons is that they're more purified. They don't have as much of the potential contaminants that you have with the leaf itself. The downside is that you don't also have the rest of the 80 or so odd other cannabinoids. And a lot of people tout that even though the best known are CBD and THC, the other ones will probably contribute a bit to the medical uses also. But those are actually approved now for things like antiemetic use. The other one that is also approved, not in the US, but in Europe, is this one, nabiximols sativex. It's actually an extract of cannabis, and it's approved in Europe, not so much for cancer-associated uses, but for spasticity, specifically with, with multiple sclerosis. And so they do exist. They're not the greatest. A lot of patients will try them, but the effects of them tend to be fairly modest. The other issue with the use of marijuana in a medical purpose is the indications for it vary from state to state. So as of right now, there's about 28 states in the United States that approve medical marijuana for medical use. There's actually only 12 now that don't approve it for anything at all, whether it's recreational or use. Or medical use. But the indications are different. Like for instance, Maine really only approves it for certain things: epilepsy and seizure disorders, glaucoma, multiple sclerosis, muscle spasticity, and then nausea and vomiting specifically in HIV and cancer. On the other hand, if you go to Illinois, it's approved for a whole bunch of other stuff, even hepatitis C, Crohn's disease, multiple sclerosis, et cetera. And so it varies from state to state. In Washington, the approved uses of cannabis include symptom-based, so chronic pain and spasticity, nausea and vomiting, anorexia, weight loss, and muscle wasting, or disease-based, so specifically in cancer, HIV, MS, glaucoma, Crohn's disease, hepatitis C, chronic renal failure. These are folks that are wasting away on hemodialysis. Also, post-traumatic stress disorder as an anxiolytic. And so in the state of Washington, these are the indications for the use of medical marijuana. The big question patients always ask me is, can I use marijuana to cure my cancer or to treat my cancer? And the short answer is you could use it, but there's no data that shows that it works. Okay, I just want to put that out there. I do not use, nor do I recommend that marijuana be used as a direct anti-cancer treatment. There's no clinical data that shows it can actually kill cancer cells. There are preclinical studies, but they've never been really used, or it's never been validated in the clinical setting. For instance, 2003, there was some data that shows CBD might inhibit the growth of AML cell lines. So this is like 15, 16 years ago. CBD inhibits the growth of breast cancer cell lines. THC inhibits the growth of lung cancer cell lines. So these are cell lines in the lab, in the petri dish. Maybe it has some sort of anti-cancer effect. There was one study, it was actually in Spain about 10 years ago, 13 years ago, had 9 patients with glioblastoma who had progressed on other therapies, surgery, radiation, Temodar, et cetera. And of the 9 patients, 2 receiving intracranial THC had a response for a couple of months. So I don't know if that's real or not. My inclination, although I'm a little cynical about this, is that if this stuff worked, somebody would have exploited it to make money already. And the fact that this was 13 years ago and there's nothing on the horizon, maybe not so much. But basically, there's no data outside of cell line studies that show it has any anti-cancer effect. So does it fight cancer? Specifically, patients ask about 2 products from an anti-cancer standpoint: Phoenix Tears and Rick Simpson oil. Have you guys ever heard of these things? Okay, Phoenix Tears and Rick Simpson oil is different from your typical run-of-the-mill cannabis that you can buy elsewhere. So these are high concentration, high potency varieties of marijuana. like 80%, 90% THC CBD concentration, which is far, far higher than anything you can find in your typical dispensary. You're talking normally about 5%, maybe 10%. So these are 80%, 90%. While there are commercially available products, a lot of people that have access to this will make it themselves. If there's like a YouTube video, you can go to a website. They teach you what the recipe is to make it. So there's a lot of variation. And so when people ask about Rick Simpson oil or Phoenix Tears, a lot of times they're proprietary. They're not standardized, like even less standardized than your usual lack of standardization in medical marijuana. And they're very high potency. Again, no data. The only data that you have are anecdotal data. Oh, I had a friend or I have a family member who progressed on other cancer therapies and they took this and they lived for a little bit longer than expected. And that's really it. That's the level of data. So that's not, I don't even know that. That's not even level C data. But people will ask about this because there's a lot of websites out there, and in those kind of situations, I have often said no, mostly because A, there's no data, and B, when you use medical marijuana in that concentration, then you run into a lot of the potentials for toxicity. High concentration medical marijuana is one of the, minimal improvement, high likelihood of toxicity. I tend to recommend against this. This is not how I use medical marijuana in my practice. And in fact, the NCI has basically sent out a statement with regards to this. Let me see. The US FDA has not approved cannabis as a treatment for cancer or any other medical condition. Right? However, commercially available cannabinoids such as dronabinol and nabilone are approved drugs for the treatment of cancer-related side effects. And cannabinoids may have benefits in the treatment of cancer-related side effects. So not as a direct treatment for cancer, however, in the context of oncology, maybe there's a role for it. So I just want to make sure that that's stated out right. So what is the role for it? A lot of times when I use it in patients who have symptoms related to their cancer or to their cancer treatments. What are those symptoms? So if you look at a recent study, this is not a medical marijuana study necessarily, but just a study of symptoms. These are the kinds of symptoms that patients with cancers have. They have pain. They have nausea. They have cachexia. They have neurologic conditions. And so these are the kinds of symptoms where, if you look at the data, there is some good, some bad, but there is at least data that show that the use of medical marijuana might have some benefit. Probably the most common is chronic and severe pain. So normally when we have a patient with pain, we treat with opioids, right? And in the middle of all this opioid controversy, what's being lost is that opioids actually do help a lot for many of our patients. 15 years ago, the reason why we got to this place is 15 years ago, there was the fifth vital sign. The fifth vital sign was, what was your pain? 0 to 10, right? And so in the context of treating that, the best thing that we have are opioids. And opioids are not bad in the proper context. However, they come with a lot of issues. Addiction is just one. A lot of potential toxicities because there's a lot of problems with the therapeutic index of opioids. However, they're important. However, if we had other medications that can help with them, that might be beneficial. So medical marijuana has often been used in the context of, can you use it along with opioids instead of opioids? What's the role for it in a patient who is also getting chronic and long-term opioid therapy? So what's the data for medical marijuana in chronic and severe pain? So there have actually been 28 studies, a total of about 2,400 people, looking at various different formulations of marijuana. Some of them were the synthetic, some of them were the smoked kind, some of them were the extract, oral mucosal, et cetera. So these were 28 different studies that had different formulations. This was from a meta-analysis that was in JAMA in 2016. They kind of put all the data together. Most, if not all of them, were placebo-controlled. And they were for various indications. Some were for cancer, some were for diabetic neuropathy, which can be fairly painful, fibromyalgia, HIV-associated neuropathy. So it wasn't limited to cancer pain, but it was anybody who had any sort of chronic and severe pain. And the results did show that the average number of patients who report a greater than 30% reduction in pain was greater with cannabinoids than placebo. So the odds ratio was 1.4. Technically, it did cross 1, so it wasn't statistically significant, but there was a a strong trend in that direction. So it seems as if in this kind of a setting, there's some good data, over 2,400 patients, that showed benefit in patients who are receiving medical marijuana. You can't really make any other statement than that because it was 7 different formulations over a course of about 20 years worth of trials. But in the proper context, there might be some benefit for patients with chronic pain with medical marijuana. Okay. Cancer pain specifically is probably a good target for this, mostly because, like I said, we generally treat it with opioids, but the problem with opioids is that it's not really optimized necessarily for cancer pain. Low therapeutic index, you have patients getting constipation, sedation, weakness. They already have that from their cancer and from their chemotherapy, and on top of that, you're going to give them more from the opioids. Also, and we know this for patients from chronic pain, tolerance leads to increased dosing, and you might be tolerant to the pain control aspects of it, but you're probably not going to get tolerant to the toxicities. And you have so many patients that are controlled with opioids but have chronic constipation, chronic weakness, chronic fatigue. Also, specifically in the case of neuropathic pain, opioids aren't that great. That's why we use things like gabapentin and Lyrica. Okay. The potential benefits with cannabinoids, it is a different pathway, specifically, it's not the opioid pathway, and it can be used concurrently. There are actually several studies with the use of marijuana in cancer pain specifically, and of the 5 studies, 4 of them showed that the improvement with the use of THCs in pain control. So there's one study, a smaller one, maybe about 15 people, 16 people, that showed no improvement, but several hundred other patients, specifically with cancer pain, were able to be treated with some benefit with medical marijuana. And the toxicities were, as you would expect, the higher the dose of placebo, minimal toxicities, dose increases this way. The higher the dose, the increase the percentage of toxicity, but the kind of toxicity you had were generally, as expected, there's some dizziness, some blurred vision, some weakness, for the most part, fairly mild. But it did increase with a higher dose. In the context of using them along with opioids, there was actually a nice study from a few years ago which looked at not individual patients, but state populations. What they found was that the states that legalized medical cannabis saw a decrease in the opioid prescription volume. So in the 5 years from 2010 to 2015, there were 23 million opioid prescriptions were used daily. In the legal states, there were 3.7 million fewer opioids used per day. And then the states have homegrown, not prescription necessarily, still, I mean, a smaller percentage, but less, but also fewer. So it seems like the use of medical marijuana concurrent with opioids can potentially result in a decrease in the requirement, the opioid requirement, specifically for pain. And in addition, even states with legalized recreational cannabis use also saw that too. So it wasn't just in the medical context. So in the medical cannabis legal states had a 5.8% lower rate of opioid prescriptions, and then in recreational states had a 6.3% lower rate. So the availability and the use of cannabis looks like it resulted in a decrease in the need and or use of opioids, specifically for pain. In terms of toxicity, for the most part, the toxicities are what you would expect. There's a couple that are pretty significant. People really don't like the CNS toxicities of it. For instance, it can cause anxiety, about 54%, can cause psychosis, 25%. Presumably that's mediated by the THC molecule because that's the one that tends to have more activity in the CNS. And so a lot of times what I'll tell my patients is that fine, you need the THC in there for things like antiemetic use and appetite stimulation, but you probably don't want to use a formulation that is uncontrolled or unopposed THC. A lot of times having a combination of maybe a 1-to-1 ratio or a 2-to-1 ratio, THC to CBD, you have enough CBD in there to serve as a counterbalance for THC, and it does tend to minimize the toxicity. The marijuana folks make a big deal about saying that in the history of marijuana use in the United States, no one has ever died of a marijuana overdose. Still true, although I'm sure they're keeping closer tabs now. All right, so that's pain. Other potential uses for it in nausea and vomiting. Patients with cancer, whether they're on chemo or not, nausea and vomiting was one of the most common toxicities. Still 28 studies, about 1,800 people. Same kind of distribution, multiple different formulations of marijuana. Not all of them were placebo-controlled. 8 were, but 20 were against some sort of active comparator, either prochlorperazine, metoclopramide, ondansetron. There wasn't emend yet back then. And so what it showed that there was a higher incidence of complete response, meaning no nausea, with the use of cannabinoids than with placebo. And it seems as if the marijuana does appear to have some similar efficacy to compazine and Reglan, maybe not as strong as Zofran. So what does that mean from a practical standpoint? I tell my patients that it's a modest antiemetic. It's not as strong as emend. I certainly wouldn't use it instead of that. It's a little bit, maybe not as strong as ondansetron, but if they also happen to have another symptom, for instance, pain, it might be some way of them being able to treat 2 symptoms with just one medication rather than others. It's also, it kind of varies too, and so what I tell my patients, they might have some increased potency, but it may not be as effective. So it's part of the sort of the package that we can sometimes use for antiemetics. Appetite. So appetite is kind of the big one. So whenever I use medical, or when I talk to patients about medical marijuana, the 3 most common symptoms are pain, nausea, and appetite. And what I say is that we have actually stronger medications for pain and nausea, but we don't actually have a lot of good medications for appetite stimulation. Remeron, modest. Again, but Remeron kind of makes you happy, so it has an extra added benefit of antidepressant effect. Megase is another one, but the problem with Megase is also a modest appetite stimulant, but it is a steroid and could have some toxicity like DVTs. And so we don't really have a lot of good appetite stimulants. So marijuana does have some appetite stimulant abilities. So not as much. There were 4 studies. All of them were in patients with HIV, not so much cancer. And 3 of them were, all of them were with dronabinol, 3 was with placebo, and 1 was compared to Megase. Megase, the reason why they did that is Megase has maybe some data that might improve muscle wasting, specifically in patients with HIV and AIDS. That's why it was used as a comparator. So in these studies, dronabinol showed a trend, not a statistically significant one, but a trend towards increased appetite and weight gain, certainly versus placebo. And although when you compare it to Megase, Megase was maybe a little bit better. So the data is okay in the use of medical marijuana. There's also a clinical trial in anorexia nervosa that showed maybe some benefit too. So the trend that you're seeing is that it's kind of a modest improvement in these toxicities. In anorexia, the dronabinol resulted in an increase in about 1.5 pounds over a 4-week period, which in anorexia is not insignificant. The issues have to do with people who worry about with medical marijuana have to do with toxicity, and it's not a non-toxic agent. I mean, any drug that you give will have some toxicities. And interestingly, the toxicities are somewhat different depending on whether it's natural cannabis or a synthetic cannabinoid. Natural cannabis, presumably because it has a higher concentration of THC, has more CNS, anxiety and psychosis, sedation, and hallucination. Also memory deficits, people who have been using marijuana for a long time, and that kind of what leads to the social sort of stigma of marijuana, as it makes you kind of dumb, it kills brain cells. It does have some effect on memory. Rarely does it cause acute psychosis. But interesting, there's some autonomic effects of it also, because it is active in the nervous system. You can get some tachycardia, tachypnea, hypertension, and some tremors. Again, these are generally mediated by the higher THC compounds. For the synthetic cannabinoids, some of it is metabolic, so you can get hypokalemia, you can get some GI side effects, nausea and vomiting, you can get some seizures and agitation along with it. Violent behavior, although less so. Coma, mostly because the CBD does tend to be a little bit more calming as an effect. So if you want to do it, and if you're having a discussion with a patient, what are the pitfalls or the issues that are there if you want to prescribe it? Probably the biggest is that while it is officially legal in Washington State, it is still officially illegal in the United States. It is considered a Schedule I drug, and Schedule I drug basically means that it has no known medical benefit. not available. Just to kind of put it in perspective, other Schedule I drugs, including marijuana, are heroin, LSD, ecstasy, peyote. Schedule II drugs are legal, although they're controlled. Schedule II drugs include things like cocaine and methamphetamines, opioids, and everything else. And so it's classified a little bit at a higher level. And so officially, even though, like I said, it's legal in Washington State, and many other states, it's officially illegal in the United States. And so there's always a controversy. If I prescribe medical marijuana, if I'm a doctor who prescribes medical marijuana, will they potentially come after me? I guess they could. They probably won't, though. So what does the American Cancer Society say about this? Supports the need for more scientific research and recognizes that the need for better and more effective therapies can overcome the often debilitating side effects of cancer and its treatment. So it's more open-minded. It doesn't say that you can or should use it, but it says that there's potentially some benefit for it. So it's neither confirms nor denies. So like I said, there's 28 states now that have legalized marijuana, and all throughout the West here. Basically, us, Nevada, and Alaska. Everybody here has legal, or is legal to prescribe medical marijuana. Interestingly, even though, for instance, it's legal in Washington and it's legal in Oregon, if you cross the border, they can get you, because technically the border is federal, right? And so I've had patients ask me that, well, if I wanted to, say, fly from Washington to California, both of which are legal, airspace is FAA, they can, so I tell my patients, don't take it with you if you go anywhere. Maybe if you drive, it's not as bad, but still, they could technically do it at borders and certainly at airports. So I wouldn't recommend doing that. You can get it when you get there. Certainly, if you're going to a state where it's not legal, I wouldn't even try it. So it's one of those sort of the vagaries of the use of medical marijuana. From a practical standpoint, if you wanted to do it, what does that mean? Number one, have it be a patient with whom you actually have an established relationship, or they're seeing you for other stuff. I've never prescribed or recommended medical marijuana to a patient who came to see me specifically just for medical marijuana. It's always a patient who I'm also treating for other things. They have their metastatic cancer, they have their chronic pain, whatever, and in the context of that, we discuss medical marijuana. Also identify the indication. You can't just say this patient has cancer, give him medical marijuana. What are you giving him medical marijuana for? Pain, nausea, appetite, what have you. And I usually document that very well. Also, document other attempts. If you have somebody with pain, did you try opioids? Did you try gabapentin? Did you try Tylenol? Things like that. There has to be the proper context. In that sense, it's not any different than anything else that we do. If you're going to give somebody, for instance, chemotherapy, you would do the same thing. We discuss pros and cons. This is the reason why we're doing it. Basically, just make sure you document it well. Also, there is a certificate, and I'll show you that. And also, the other side of this is you document the results. So like any drug, you try it for X amount of time, and you reassess to see if it works. If you're going to give somebody an antihypertensive, you don't not see them again and never check their blood pressure. Similarly, if you're going to give somebody a medical marijuana for pain, maybe 2-3 months later, you check, did it help? And in that context, you just make sure you document it. So basically know that you're giving it not just without reason, you're giving it for actual medical reason. If you've never seen it before, this is what the medical marijuana authorization form looks like. It's actually not a prescription per se. It's just a documentation that says that this patient has a real medical reason for taking medical marijuana. This part is the patient. A lot of times my patients maybe don't have the strength or the stamina to actually go out and pick it up themselves, and so they'll have a designated person be the person to get that drug for them, and so they have to document it. This is the part where we fill it out, or I fill it out. It has the indication, cancer, HIV, post-traumatic stress, etc. And then for how long it's good for. For an adult in the state of Washington, you can have a certificate for up to 12 months. Oh, this is statewide. I'll be the next one. It's the Washington Department of Health. And so if you go to their website, you can document this. Oh, you can download it, and it has to be printed on prescription paper. So it's not just regular paper. It has to be like the triplicate, or what used to be the triplicate paper. And so, yeah, the Department of Health is actually the SB 5052 was the state law that documented the legality and the parameters for medical marijuana. It defines medical versus recreational marijuana. Also talked about the need for medical endorsement. That's what that paper was. It's a medical endorsement for the medical need for medical marijuana. Also, it determines the place of this person called a consultant. So before this was legalized a couple of years ago, the medical dispensaries for marijuana and the recreational dispensaries were separate. Now there's just one entity, but if you're a dispensary that wants to be able to function in the context of medical marijuana, there has to be somebody in that dispensary that has a consultant certificate. And consultant certificates require that you go through training for the state. There's several hours worth of continual education on a yearly basis, and they have to pass a test so that they have a consultant certificate. And those are the people that work in the dispensaries that are able to dispense medical advice along with just recreational marijuana. If you have somebody that you give that to, because you don't really need that certificate anymore. Nowadays, you can just get it anywhere. You don't need a medical certificate because in Washington, recreational marijuana is legal. But if you have somebody that has a medical certificate, it does give them certain benefits. You can get larger amounts. If you're just buying marijuana recreationally, it limits you to about like 2 ounces, whereas you can get like 3 times as much if it's a medical product. This is probably the biggest one, no sales tax. It comes out to about 35% sales tax, recreational, and you don't have to pay for that if you have a medical use for it. Also, arrest protection for the patient and the surrogate. If you have that as a documentation, if for whatever reason they're stopped someplace, it does provide some protection, at least within the state of Washington. Again, you can't take it with you at an airport or anything like that. But it does have some benefits if you have somebody who has a medical use for marijuana and they have the certificate also. And again, you can just download it at the Department of Health website. And if you want to print it out on a non-transferable paper, like the blue paper. All right, so what exactly did we just talk about? So first of all, cannabis contains probably greater than 100 cannabinoids, most abundant of which are THC and CBD, which activate receptors along the endocannabinoid pathway, resulting in its varied side effects. Currently, cannabis is a Schedule I drug, according to the United States federal government, which means it has a high potential for abuse. Currently, officially, no acceptable medical use, despite all the data that we just talked about. Studies have shown that it does have potentially some benefits in certain things, including acute or chronic pain, nausea, vomiting, and also anorexia. Currently, it is legal in 29 states, along with Guam and Washington, D.C., although, as we discussed, the indications vary. The problems with it really lie in the standardization. I've never been able to tell my patients, take this brand for this many times this often, because that kind of standardization just does not exist. And it kind of varies. Even if it's the same product, and if it's different batches, they have some variances in there in the percentage of THC and CBD. And so from a practical standpoint, what I tell my patients is, try maybe 2 or 3 different things, different formulations, and see whichever one works for you for whatever indication it is that you want to use. The physician recommendations for cannabis must follow strict guidelines for documentation, like what you would do with anything else, along with a standardized authorization form. And currently, even despite everything else that's going on, the government policy appears headed in the direction of leniency. Every year, there are more and more states that are legalizing both medical and recreational use of marijuana, but officially, from a federal standpoint, it's still a Schedule I, a Class I drug. And this was the JAMA article, I think it's 2015, that had actually a really nice meta-analysis of all the different studies historically that have shown some benefit with medical marijuana. So it was the June 2330 in 2015, so volume 313, number 24. And there's, where was that? Cannabinoids for medical use, a systemic review and meta-analysis. It's a really good source if you want to get. And there's been a couple others since then, but that's probably one of the biggest in terms of meta-analysis. Thank you very much. Any questions? Yeah. Mm-hmm. Sure.
I practice in Utah. That's why
Mm.
This is all kind of, they just legalized medical marijuana. We still have to figure out what we'll do with it. I guess one question would be, do you ever recommend somebody use CBD and not THC? So is there any
Sure.
CBD?
Yeah, I mean, so CBD, actually a lot of people who want to use marijuana, especially the older folks that, like in their 60s, 70s, 80s, that grew up with the whole, just say no and all that kind of stuff, they're very hesitant. And if they want to try it, in the community, it seems as if CBD has more of a medical connotation, whereas THC has more of a recreational connotation. So a lot of people will try using just CBD because that's acceptable to them from a mental standpoint. CBD, I think, works really well for certain things, especially for pain. There is some benefit, especially for neuropathic pain with CBD. THC looks to be, whenever I tell patients to do that, it's usually, that's what I use or have them use for nausea and appetite stimulation. But I also caution them against using THC unopposed. I've never recommended that, mostly because then they get really jittery, they get very anxious, and that's where they have the mental symptoms, like the high, and most patients really just don't like that. And so from a practical standpoint, what I recommend is either a 1-to-1 or 2-to-1 ratio of THC to CBD. If patients want to try CBD by itself, that's fine. It's just that it probably won't work as well against things like nausea and appetite stimulation. It might work for pain, though.
And when you say, I guess I'm pretty naive, when you say neuropathic pain, you're talking about topical or you're talking about
Both. There is there are several actually formulations that are just topical, but oral can sometimes work for that also.
And then that form,
Mhm.
I guess, because we've been, our division has been giving a like kind of a generic form that says
Mhm.
they have a condition that's acceptable for medical marijuana, but I'm not prescribing it.
Yeah.
What is that form binding you as far as, you said you're not, it's not a prescription?
It's not a prescription, yeah. It's just a certificate that says that the patient who has the form has a medical reason for obtaining a cannabis product. And so practically speaking, what that means is they can get more of it, it's cheaper for them, and it has some protection against any prosecution. Hmm? Yes, sir. Hey.
One of the 3 states that was able to use them for that.
Mm-hmm.
Where do you place, say, Marinol, Dronabinol in the spectrum of what it will?
Oh, so Marinol and Dronabinol, although I use them rarely, those are illegal. So those are prescription. So it's my experience with them is that they tend to have very modest effects. I've only ever used Marinol, for instance, in nausea. I've not used it for appetite stimulation or pain or anything else. I've had a couple of patients of mine try that. The benefits of it are fairly mild. Or fairly minor. I haven't had too much in the way of success with that. And also, and I think this is probably true in the general community feeling at large, the issue with things like Marinol and Dronabinol is that it's synthetic. It's a delta 9 THC, so it's the tetrahydrocannabinol molecule, but because it's synthetic, it's felt to be a lot of times overly pure. And so one of the good things about having the natural product, supposedly, is that you don't just have the CBD and THC, you have all the other 80 other minor components of the cannabinoids that probably have some interaction with the CB1 and CB2 receptor also. And so for many patients, they bypass the Marinol and they'll just try the marijuana. It's actually probably easier for them, especially here, it's just easier for them to use. I've had a couple of patients try Marinol specifically for nausea. It hasn't really... My experience with it hasn't been very successful. All right, well, thank you guys very much. Oh, you had a question? Oh, well, thank you guys very much.